The methods to collect cytology samples from the lower respiratory tract. There are many methods like sputum sampling. Then we have the various methods to collect samples from the bronchus and the alveoli, which includes bronchial washing, bronchial brushing, then Bronco Alveolar lavage, then bronchial aspiration. We'll have a transbronchial needle aspiration, and also the recent one, that is the EBUS, that is endobronchial ultrasound guided FNAC or aspiration technique. So we'll briefly cover all of them. And first, coming to sputum cytology. Sputum, it is very important to note that the sputum has to be collected after discarding or after cleaning the oral mucosa. That is, first the person has to be told to wash his mouth properly before collecting the sample. Then he also has to rinse his nose, so the the nasal passages as well as the oral mucosal surface has to be clean, otherwise there is a chance for contamination. And then the person has to be told to take a deep cough, that is, the sputum should come from the lower tract itself. So we have to teach them to take the sample, or to bring out the sputum from within the lower respiratory tracts, from the alveoli, and it should be deep samples, deep sputum samples. And it is always ideal to take the sample in early morning. And another thing is that the sensitivity to detect cancers increases with the number of samples that we take, or number of sputum samples that are examined. So if you just examine one sputum sample, there is a chance that we can miss malignancy. But as the number of sampling increases, like if it is 3, 4, 5 sampling, consecutive sampling on consecutive days, we have a more chance to detect any cancer. So that is one thing. And for sputum sampling, when you examine in the microscope, we have to understand, we have to always look for adequacy, that is to see for alveolar macrophages. Now, as already told, the sample has to be means from within the respiratory tract, from deep tract, that from the alveolus it should come. So if a person is not able to cough up the sputum which is adequate, we can give him, we can cause him to bring out the sputum by using nebulizing with saline. So that is a way to induce a sputum if a person is not able to produce adequate amount of sputum. So again, once you get the sputum, there is a technique to spread the sputum onto the slide. It is called pick and smear technique. So you have to examine the sputum under a petri dish, and ideally keep the petri dish on a dark surface, and look for any bloody areas as well as any solid areas, and those has to be picked up and put on a glass slide, and a smear has to be made. So that is how a sputum has to be sampled. And then look for adequacy, that is the presence of alveolar macrophages. Right, so that is about sputum sample. Then we have bronchial aspiration. Bronchial aspiration is quite straightforward, in the sense that bronchial means we can use flexible bronchoscopy, and when you go into the bronchus, if you see any bronchial secretions, you can aspirate that secretion, and that secretion can be examined under the microscope after a smear is prepared. Now that is bronchial aspiration. So if it is difficult to get a bronchial aspiration, we can do a bronchial washing. Bronchial washing is nothing but injecting about 10 ml of saline, sterile saline, and then aspirating that back. So if you go to a bronchial area and you see you have to get the washing from an area, that is the mucosal area has to be washed with saline, and whatever saline that we have injected, we'll aspirate it back. So that is the washing that you get. This can be used for cytology examination. Also can be used for liquid based cytology examination. So that is a good thing about bronchial washing, and both these techniques can be used to diagnose any cancer or not. Then we have Bronco Alveolar lavage or Bronco Alveolar lavage is actually more used for infections, and it is a technique where you inject, again it's something like a bronchial wash, but here the bronchoscope goes much deeper and almost reaches to the lowest end of the tract where the bronchoscope can go, and once it reaches there, we can inject a saline, and then it can be aspirated back. The thing is that it goes much more in deeper, that is almost to the alveoli. So the aspiration will contain alveolar macrophages much more than the bronchial epithelial cells. So we have to decide what we want. We want a bronchial wash or a bronchial alveolar lavage. So bronchial wash is much higher up in the tract, and bronchial alveolar lavage is more deeper or more lower down the tract. And bronchial alveolar lavage is more used to look for any infections like pneumocystis carinii in people who are immunocompromised or people who have HIV. So that is one way to look for the infections. Then it can also be used for looking for any cancers. So that is bronchial alveolar lavage. Then what we have is transbronchial needle aspiration. Transbronchial needle aspiration. In that, again, we have this flexible bronchoscope, and by visualizing through the tract, means through the bronchial tree, we'll identify an area where we want to take a specimen from, and a needle is inserted, and with the help of that needle you can take a sampling, and usually TBNA is used to take samples from the mediastinal lymph nodes. So you go through the bronchoscope and you identify area where you want to take a sample, and then the needle is inserted, and through the bronchus, the bronchus is basically pierced, and the needle reaches the mediastinal space where we have the lymph node, any enlarged lymph node, and then the lymph node sample is taken. So naturally, if you are taking a lymph node sample with this technique, you have to see the adequacy, and adequacy can be seen microscopically by the presence of adequate amount of lymphocytes. So that was again used for looking for any cancerous or any neoplasm that has metastasized to the lymph nodes, the mediastinal lymph nodes, or we can also use that for sarcoidosis and such conditions. Then another very similar technique to TBNA, but which we use the ultrasound, is called EBUS, or endobronchial ultrasound guided aspiration, FNAC, EBUS FNAC, or aspiration, needle aspiration. So in EBUS aspiration, the bronchoscope also has an additionally fitted ultrasound probe in it, and while the bronchoscope is inside the bronchial tree, we can use the ultrasound the ultrasound probe that is attached to it to guide another needle to exactly point to a lymph node in the mediastinum, and so that it is much more precise. And EBUS can be used to take precise samples, and with the help of EBUS we can reach more areas, more lymph nodes, which was not possible before. And another thing about EBUS is ROSE, or rapid on site evaluation. EBUS specimens, we can see the adequacy of EBUS specimens at the site itself. So a cytopathologist can be present at the site, and he'll examine for the adequacy of the sample collected by the EBUS technique. And so it is quite a very good method, because it can be used to stage cancers, and even though it is a very expensive method, if you get the adequate sample, and if a correct diagnosis can be made, further down the line the cost can be reduced in many ways. So that is EBUS. Then another method is transesophageal needle aspiration. In that again we can use ultrasound guided, techniques, and that again can we can access some lymph nodes which is not possible by other techniques. So these are the basic methods. The transesophageal is the last one that can be mentioned. Transesophageal, esophageal. So the techniques that we can use to collect samples are sputum, which is the easiest and which causes least irritation to the patient in all ways. And sputum cytology, one problem is that it is always better, it is not very sensitive, but it is quite specific. So if you don't find a carcinoma by sputum cytology, it does not mean that the patient is not having a cancer, because the sensitivity is quite low. And then we have discussed all the other things. So that is about it.